Today I'll go over what a simple, relatively straightforward shoulder complaint evaluation would look like. So let's say the patient comes in and the verbal history reveals that the pain is located around the lateral shoulder, a little bit into the deltoid. It's been there for about 3 months. There was no apparent reason that it started. What makes it worse is certain activities at the gym, maybe like pushing up off of a chair to get up, sleeping on that side, and it's intermittent. So the patient can avoid the pain by avoiding those activities. It doesn't really linger after the activities, but some days it'll kind of ache just at rest when working at the computer. So the diagnostic questions from that verbal history: onset, how long ago did it happen? Is it constant or intermittent? What makes it worse? And where are the symptoms? I've asked about all the other locations of symptoms and they're negative. And then finally, do you lose motion? The patient says, I haven't really noticed that it's extra stiff. It seems normal to me. So those verbal history answers are starting to make me think, all right, it could be coming from the spine because of prevalence, and also because just sitting at a computer can create that symptom. I find in about 50% of patients, the shoulder area pain is coming from something in the spine, either in the neck or the mid-back. The verbal history is also making me think it's a high likelihood of a shoulder joint mechanical problem. And that is in contrast to a structural lesion. Mostly from the verbal history, what I'm gathering is that there was no trauma, and there was no even like minor trauma or offending incident that started this process. So it's probably not a structural problem. A ligament didn't tear. It's not a fracture. It's not a tendon tear. It's not a labral tear, a biceps tear, etc. So in the verbal history, I would also go over red flag considerations. And obviously, we would talk about more than just that 1-minute history. But those are the important things in terms of how I'm starting to think diagnostically. So I'm thinking shoulder joint or spinal joint. Pretty sure it's not a red flag at this point. I'm pretty sure it's not a structural problem. And the orthopedic story of impingement, we can get into that another time, but I don't think that pathophysiologically that makes sense. And I don't find that to be a valid diagnosis when I'm looking at a patient's complaint. So then part 2 of my orthopedic evaluation for a shoulder complaint would be taking mechanics. So range of motion, strength, and function. Those are going to be the top 3 for this patient. I'm not going to do nerve tension based on what we gleaned from the verbal history. I'm not going to do sensory testing, reflex testing. These are going to be my main 3. So let's walk through his range of motion. Let's say, and this is a common presentation, that's why I'm choosing to use these range of motion and functional deficits and verbal history. So let's say range of motion is mild loss into elevation or flexion with pain at the end. So into flexion and also into abduction. So I would look at both limbs, which gives me a great comparator. And so like this side would be normal and normal, pain-free. And this side I would put minimal loss of flexion with pain, and minimal loss of abduction with pain. And we can even further clarify with end range pain. Pain during motion and end range pain tell me different things about the physiology and what's happening. I would also look at external rotation in standing. And again, at the end range, I'm applying some overpressure, because I firmly believe you don't know how a joint behaves until you assess the entire range of motion. And most movements require overpressure to get to the end range. So within safety and within the patient's tolerance, I'm going to apply that passive overpressure to the end of a joint. For example, this is how much your elbow bends into flexion, but if you push, you get a few more degrees. So overpressure is very key in understanding what's going on and helping to get the good data for the pieces of the puzzle. So we have that. Let's say internal rotation is normal. Let's say horizontal adduction across the body is normal. Let's say extension is normal. And let's say functional internal rotation is considerably limited with pain. So if the left one, for example, goes up here, the right one's only going up there. So we'll say moderate loss of functional internal rotation, FIR, with pain. So that's the range of motion. If it's really painful, I'm not going to push it passively. So let's say it was really painful in the internal rotation, so I didn't even push it up into passive. Okay, so strength testing. Let's say flexion testing is normal and neutral. Abduction testing is strong, 5 out of 5 manual muscle test, but painful. So we have painful abduction. And then let's say external rotation, which I tested neutral, is extremely weak. So instead of a 5 out of 5, I would give it a 4 out of 5, but painless. So external rotation, 4 out of 5. Internal rotation, which I tested neutral as well, strong, no problems there. I do not typically lie the patient down and do posterior musculature strength testing. For example, extension or horizontal abduction, rhomboids, all those things. You could definitely test extension in standing as well. I don't find those to be fruitful, but anyone could do them. The amount of testing and the tests that I choose to do are informed by the verbal history and the mechanics that I found up until that point. And they're also informed by time and what I think is most apropos for this presentation. So I'm not going to do posterior musculature testing for this patient. Now, function, let's say that pushing up off the chair on the armrest is painful, so rising, we can elicit that in the clinic. And let's say doing a shoulder press with 10, 15 pounds, we test that in the clinic and that's painful, so a press. At the end of my verbal history, I'm always asking the patient, is there something we can do right now that would recreate your pain? And it could be something like lying on that side on the table, or putting on a backpack, or reaching to tie my shoe. I want to recreate that patient's symptom if it's tolerable, because I am such a cause and effect clinician that I want to gather the relevant baselines in part 2 and symptoms from part 1. If the symptom is there, obviously, when we start, I want to gather that data so we have the baselines for comparison, because now we're going to go into part 3, which is the repeated movement testing. And the repeated movement testing, if it's fruitful, will affect these baselines. For certain diagnoses, repeated movement testing will not change the baselines. But in the presence of a joint derangement, which is a diagnosis put forward by Robin McKenzie, which I subscribe to, I think this is a very powerful clinical diagnosis. In the presence of a joint derangement, a mechanical problem, imbalance, whatever you want to call it in the joint, if we repeatedly move it some directions, these are going to get better. If we repeatedly move it in other directions, no effect. In other directions, we could make it worse. So at this point, he seems like a pretty straightforward patient to me because I've seen this pattern a lot. So functional internal rotation, often limited and or painful with patients with shoulder complaints coming from the shoulder joint and from the spine. So that one piece alone doesn't typically tell me a diagnosis, but when you put all the pieces together, you start to see patterns. End range, elevation, pain, and limitation, also very common. So Scott Herbawi does a small interview on YouTube, and you can look at that video. He describes some of the patterns that clinicians who use repeated movement testing are finding in patients with shoulder complaints. They're not set in stone. This is an evolving science. As we get more clinicians who use this algorithmic testing, we'll gather more data over the years. So this is part 2. Part 3 is, for me, repeated movement testing. Now, other clinicians, and sometimes myself as well, will use orthopedic special tests. So maybe I would want to do a subscapularis tear test, or a slap lesion test, or a dislocation apprehension test. Those orthopedic special tests have a time and a place. I find them rarely to be helpful diagnostically. The false positives are very, very strong because a lot of them presume to be testing certain structures. And while they may be testing that structure, they're also testing a host of other structures and processes, right? If I push down on this arm and you can't hold that, can we incriminate just the muscle that abducts the arm? No, right? If there's an infection in your arm, you wouldn't be able to hold against that pressure possibly, or a fracture, or in my estimation, a lot of these problems, you can't hold against that force because the joint is mechanically not sound, right? The mechanical advantage, if we could go so far as to make this hypothesis, the mechanical advantage is gone, and therefore it can't support that weight. So part 3 for me is not usually orthopedic special tests or other tests such as images, x-rays, CTs, MRIs. It's almost always repeated movement testing. I find it gives me the best answers. So for him, let's say in part 2, again, for this patient, I did not take spine baseline, but I often do, but I'm trying to keep this short and sweet for the viewer. So in part 2, I did not take spine baselines, and let's say in part 3, I did not do repeated movement testing of the spine. Let's say we go just to the shoulder. So because of the patterns that I typically see and the prevalences that I am aware of and that I observe in my own patients, I will start with functional internal rotation. Yes, it's painful, but that's not in and of itself a reason not to investigate that motion. So let's say I have him push up as far as he can go and back down. So up, into the pain, and back down. And I'm questioning as the patient does it, number 1, number 2, all the way up to number 10, if we get there, what's happening? Is it getting stiffer? Is it getting looser? Is it getting more painful, less painful? Is it staying the same, right? Let's say it stays the same. It's like, yeah, I don't know, it hurts every time I do it, but when I come back down, it's good. But when I push up, it hurts and then I come back down. So it's like an on-off switch. So it produces the pain but doesn't stay worse. Let's say we do 10 and then I retest usually the most important baselines that I choose, because time permitting, I'm not often with patients going to be able to test all 8 things again. So sometimes I do. It's based on time and based on my choice. But let's say I quickly look at retesting external rotation because it was so weak before. And let's say I retest it again and now it's strong. So now it's 5 out of 5. So just doing 10 made that 5 out of 5. This is about the same. This is about the same. This may be a little bit less painful. Range of motion going into functional internal rotation is the same. Pushing up off the chair is the same. Shoulder press is the same. So the only thing that maybe changed after that 10, if I had had the time to test all of those baselines again, would be the external rotation is now strong. It's 5 out of 5 versus 4 out of 5. Okay, so I want to do more. So another 10, up and back down, up and back down, pushing into that pain. And this time when I ask him what's happening, he's like, oh, you know, it's not quite as painful the more I do. And I'm getting a little bit looser, right? So maybe there's a 4 or 5 inch difference between the amount of rotation on the left versus the right. It's getting a little bit looser. So after that 10, making sure we're not exacerbating the pain at rest or creating pain at rest, I'll retest a few. So I don't need to retest this again. It's already 5 out of 5. Let's say I push down on this. It's like, oh, that's considerably better. And I say, how much better? It's like at least 50% less pain. Okay. And now this, it's still painful, but it's moving a little bit more. And then, okay, how about pushing off the chair? It's like, yeah, that's better. I give patients a choice. Is it worse? Is it better? It's about the same. I try not to ask leading questions. I try to go with, is it worse first, so that they don't think I'm trying to make them say what they think I want to hear. All right, so now I'm feeling a little bit more comfortable with functional internal rotation. I'm starting to think this might be a joint derangement as a diagnosis, and the directional preference for this patient might be functional internal rotation. So I'm having him now add a little bit of overpressure with his other hand. It seems safe. It seems appropriate to help that joint along. So moving the hand up higher. So up and pushing, up and pushing. And as he does that 2, 3, 4, up to 10 times or so, 10 is not a number set in stone, but we have to choose a number. So I typically do sets of 10 with extremity joints. It gets a little bit looser, a little bit less painful each time. And now we retest the baselines again, and this is at least 30-40% less painful. And then pushing up off the chair, markedly better. Shoulder press, still painful, but better. So I'm starting to see the big picture is when we move that joint into internal rotation behind the back, baselines get better. And that's why this is a cause and effect kind of algorithmic assessment, right? If it's a tendinopathy, or if there's a fracture or an infection, or if this is coming from the spine, I would not expect moving the joint this repeatedly into internal rotation would have an effect. Yes, we're always balancing against a warm-up effect, right? Maybe you're just moving the joint in any direction and it's getting better. And that can definitely be true and lead us astray. That's why the repeated movement testing is continued at home, because 30 movements or 40 movements in the office could just be, oh, it's better because it's warmed up. And I understand that criticism, and that's why it has to bear out over 2-3 days. You have to do this 10 times every couple hours to get a couple hundred reps under our belt. That will prove to me that it's not just warmed up, right? That these things are getting better, all these baselines are getting better and staying better. Conversely, or in addition to the possible warm-up effect, you could disprove that by moving the patient in another direction and making everything worse. For this example, I would not do that. I would not move the patient into repeated external rotation or repeated flexion and see if I can make the patient worse. But if it doesn't show reproducibility over days, and it doesn't show reversibility, right, with moving in the opposite direction, or if it shows those effects, it's reproducible and it's reversible, then it would give me more credence with the idea that this is a joint derangement and internal rotation is a directional preference. So I send the patient home with this. It's one of those philosophies where testing becomes treatment if the testing is fruitful, and it's not trial and error. I don't like it when it's kind of called trial and error, because I'm picking this movement for a reason based on years of experience. It's an informed investigation, and it's based on, we did 30 in the clinic and I saw a cause and effect, and I need to understand if that cause and effect bears out over several days. So he will test it over time, about 10 every few hours at home. Possibly, if he must go to the gym, do it right before the exercises that seem to hurt. Come back with that data, but try to avoid things that obviously piss it off. Like, don't go and try to get off the chair 100 times for no reason. And let's say the patient comes back in 3 days and now baselines are all 75% or more better, right? My decision at that visit 2, is, does the patient need more time with the same exercise? More time with the same exercise with more force, or possibly sustain that internal rotation up the back for 30 seconds or 10 seconds? Or have we gotten what we need out of that specific directional preference and now it's time for another one? So that's my clinical conundrum that I have to figure out on visit 2. And we'll leave it there, but that's what I'm thinking. Do we need more time or do we need something different? So I would test internal rotation more and see, again, what's the effect on the baselines. Because I would still expect, if we're doing 30 repetitions or 40 repetitions at a time, I would expect that volume to create an observable change with the baselines. So just to recap, this is an example of a diagnosis of shoulder derangement, which is a clinical diagnosis that was hypothesized and put forward by Robin McKenzie in his textbooks and his books, Treat Your Own Shoulder, Treat Your Own Neck, etc., etc. I have studied his work. I believe it is a valid diagnosis that we can make in the clinic, and I stand on it mostly because it's so cause and effect, right? It's not that theoretical in terms of what we're seeing with the patient. It becomes theoretical when we talk about what is actually happening in the joint. I think it's something intra-articular mechanical in the joint, but it could also be something somewhat outside the joint. So we're not quite sure about that stuff, but at the end of the day, we need to say, do this, and do the baselines and the symptom baselines improve, right? So shoulder diagnosis, or diagnosis of shoulder joint derangement, directional preference of functional internal rotation. And once this patient, let's say that's all he needs, and he comes back after another week of doing it and he's 100% resolved, we would then taper the exercise and decide on a maintenance plan and look and hypothesize about what could have caused this in terms of daily life activities or gym activities. and creating a maintenance plan that worked for this patient. Some people like to be proactive. Maybe they'll do that exercise at the gym or do it every morning when they brush their teeth. Or some people just say, hey, I have this in my back pocket when my shoulder is a little bit stiff or painful. I use this to restore normal mechanics. So it's up to the patient, and I try to present those options to the patient when we discharge. If you have questions, please feel free to submit them, and I'll do my best to try to answer.